Hi, all. Thank you for joining. We will give everyone a few minutes to sign in, and then we will get started. Great. Thank you all again for joining this webinar. This is our fourth webinar of this year, and we really appreciate you all coming back multiple times to join us for these webinar sessions. My name is Miriam Khan. I lead communications for Gradient Health Systems, and I will just be doing a couple housekeeping announcements at the top of this webinar before we get started, and then I'll turn it over to our moderator. As always, if you have any questions during the webinar, please use the Q&A feature to ask us. You can also use the chat function if you have any technical difficulties or any issues during the webinar. This webinar is being recorded, and you will receive a copy of the recording following the webinar, either in your email or on our website at gradienthealth.org or on our YouTube page as well. If for some reason you don't receive it, feel free to email us at customers@gradienthealth.org. As always, if you have any questions or feedback after the presentation or would like to see any topics covered in the future, please email us at the same email address at customers@gradienthealth.org. And today we'll actually be trying a new feature. We'll be doing a few polls during the presentation. So you will see a polling option pop up on your screen during the presentation. Please feel free to answer those as we go along. We'll make it a bit more interactive as we go through this session today. That is all from me. I will now turn it over to our moderator to do some introductions and get us started.
Thank you very much, Mariam. Once again, welcome everyone. We really appreciate you setting up our time and joining our webinar for discussion and sharing this experience. So today we'll be discussing one of the important topics. We all know in anesthesia, daycare surgeries, they are kind of increasing. And of course, every team is important. Surgeon, nurse, patient themselves to support everyone. But I think anesthesia, we are playing a key role when it comes to daycare. So I've been moderating this session, and we are to hear from your experience and so forth. So our scope today will be discuss the introduction. We cut the advantage. We'll try to see the criteria for patient selection. Basically, what are the anesthesia consideration? What are the needs? What for the facility for them to do the daycare cases? We'll also try to see how does errors come in, and actually it's also one of the important component when it comes to daycare. And also try to touch some recommendation and see, of course, looking at errors in our settings, which we understand. And if you do some review, you'll see in low-income countries, especially in Africa, we are not doing much better comparing to others. So we'll try to see some recommendation. So with us, Dr. Kev. Next slide, Mariam. So Kev will be presenting. Dr. Kev is giving anesthesia in Tanzania. He's based in Kilimanjaro in the hospital called KSMC, which is the teaching hospital for KSM. Presenting to us this important topic. So I will welcome Dr. Kev for presentation. Once again, Karibu sana.
Thank you. So, good evening, everyone. I hope everyone can hear me very clearly before I begin.
Yes, we can hear you.
Let's continue, Kevin.
So, thank you for joining me today. As stated earlier by Dr. Sweetbird, today we are exploring more on this transformative shift in the healthcare, the rise of the daycare surgeries. So let's begin with this poll. Which of the following should be one of the minimum standards for provision of safe daycare surgeries? So I think at the end of this session, you'll be able to answer this, and you can answer through the pop-up screen which has just appeared in front of you. You may continue. This is the second poll. Which of the following is true about the daycare surgeries? Also, as we go on this presentation, we will be able to answer these first two questions. Thank you. Next slide. So that's the poll number 2. So you can continue answering that poll while we are going on. So as I said earlier, we're exploring a transformative shift in the healthcare delivery, the rise of the day case surgeries. This innovative approach is redefining how we use or how we perceive and experience surgical procedures. So historically, in the past, undergoing surgery often meant a prolonged hospital stay, significant disruption to daily life, and considerable financial burden. However, due to the advancement in technology, both medical technology and different surgical techniques, it has paved the way for a more efficient, cost-effective, and patient-friendly solution, a day case surgery. So let's all imagine a world where you can have a necessary surgical procedure in the morning and you return to the comfort of your home by the evening, all while minimizing the risk and enhancing the recovery. Isn't that beautiful? So if you can ask me right now, I would say it is beautiful. And that is a promise of the day case surgery. So by definition, the day case surgery or the day surgery is defined as the surgery for which the patient is admitted and discharged on the same day. And nowadays, they've been more popular around the world. It has been the most popular practice in the world. So historically, just in short, in the UK, the Department of Health has recommended that at least 75% of the elective procedures should be performed as a day case surgeries. And also the International Association of Ambulatory Surgeries has been promoting this worldwide since 1995. So you can see it's been more than 20 years or even before than that. So the WHO in 2007 has published a policy that facilitates this aim. So it's called the day surgery, making it happen. Next slide. So most of the cases which formerly would have been required inpatient services now are daycare cases, and as said previous by Dr. Sweetbert, as anesthesia, we as anesthetists, we play a pivotal role in achieving successful outcome for this day surgical patient. Next slide. Next. So here are some minimum operation standards for the day case surgery. So you should have an appropriate patient selection and screening. So ideally, we should be able to create a criteria for patient eligibility based on their medical history, physical status, that's the ASA classification, the type of surgery. So a thorough preoperative assessment is very vital, and you should be able to stratify your patient and the surgeries according to the risks. Also, the ability to provide care for medical emergencies. So you should have a well-defined emergency response protocols and availability of necessary equipment to handle complications. So in case of any complication that may arise during your daycare case surgeries, you should be able to provide the care for the medical emergencies. So the ability to manage patients who cannot be transferred home. So there are some centers whereby they are well known that that center is specifically for day surgery. So if complication arises in between, during or post-operative, you should be able to manage those patients. And you should have a clear, a well-dedicated post-operative recovery area with appropriate monitoring and nursing care. Also, teaching, training, and supervision, and some of the research opportunities are really good in this day case surgery spectrum. Next slide. So right now we'll just dig into various aspects that can make the daycare surgery a preferred option for both patients and healthcare providers. So I would try and divide these benefits into three: the patient and families benefits, the hospital benefits, and the healthcare system benefits. So starting with the patient and family, so it's more of a personalized care, or we can say patient autonomy. So here the patients maintain the greater control over their recovery process and the environment. And this will enhance patient empowerment in the involvement of their own care. Also, other benefits include the recovery in a familiar home environment. So you can imagine, like, recovery in the comfort of one's home can lead to better patient outcome and satisfaction. And it's even said that patients often experience less stress and anxiety at home compared to staying in the hospitals. Also, these daycare surgeries, the other benefits will reduce the hospital stay. So patient can return home on the same day of their procedures, minimizing the disruption to their daily lives and routine. And also, this will help to reduce exposure to hospital environments, of which it can lower the risk of hospital-acquired infection and other complications such as EVT. So coming to the benefits for the hospital, it has a cost implication for the hospital, so 25 to 75% lesser. So this can help the hospital to better allocate their resources. So it will reduce the demand for inpatient resources such as nursing, ward facilities, thus allowing hospital to allocate resources more effectively. Also, other advantages from the hospital point of view, it will improve the patient flow. So by doing more of these daycare surgeries, it will free up inpatient beds for the patients who require more intensive care, and it will improve overall patient flow and hospital capacities. And also, it can also increase efficiency because the daycare surgeries allows more efficient use of operating rooms and hospital resources, enabling more procedures to be performed. And it will also create a shorter turnover time between the procedures so that it can increase the overall number of the surgery performed in a day. So into the healthcare system, it containing costs, whereas obtaining high quality, accessible, and effective treatments. Next slide. So these are the advantages I was saying. Next slide. Next. So this is the poll number 3. What are the advantages of daycare cases over long admission surgeries? So you can answer through the pop-up poll that has appeared in front of your screen. And we will get the answer at the end of this session, I think. Next slide. So I will take you through the day surgery pathway. So this, it entails you from the time out, from the day you've started planning. Now this patient is outpatient as of now. We are planning the patient for the daycare surgery. So it's the pathway which take us through every single step until the patient is discharged from the ward. So I can simply, I can simply divide into 4 phases. There is the preoperative phase, where in the preoperative phase, there is patient selection based on the criteria and the risk stratification of which we will see the criteria to admit the patient for the daycare surgeries. Also in the preoperative phase, we will do a thorough preoperative assessment for the optimization. Also, at this moment, it's the time now we can talk to our patient. We educate our patient, inform our patient everything about the procedure, about the anesthesia, about any plan you're planning to do, fasting guideline, and what to expect on the day of surgery. So the second phase is the day of admission. So on the day of admission, it's just a routine registration and documentation as usual. We record the baseline vital signs and assess the patient's current health status. We ask about the fasting compliance. Remember, we have talked to the patient prior and we have instructed them to fast. So we are asking for the fasting compliance. We put an IV access and we can pre-medicate our patients on the day of admission. The third phase is the intraoperative phase, which includes the anesthesia management and the surgical procedure itself, of which it will be well elaborated on the anesthesia consideration of the daycare surgeries, and also the postoperative phase. So in the postoperative phase, this is the last phase of the pathway, whereby we should be able to provide an immediate postoperative care. We should have a well-organized discharge criteria. We should have a very good and clear discharge instruction to the patient, and the follow-up care, whether by the telephone or in-person follow-up, for at least 24 to 48 hours after the surgery. And also, we should also have the emergency contacts, whereby the patient can contact you if there is any complication that may arise at home. Next slide. Now we are going into the anesthesia considerations. So patient education is very crucial. So patients are educated on everything about the procedure, about the anesthesia, and what to expect. And even on the discharge, you should give the patient discharge instruction by providing patient with detailed instruction regarding activity restrictions, pain management, wound care, and follow-up appointments. And also the emergency contact, as I said earlier, it ensures patients know how to contact medical personnel in case of postoperative complications. So safety and efficiency, we are all aware that protocol and checklists are really important when it comes to safety and efficiency. So we should implement standardized protocols and checklists to enhance safety and efficiency, and team communication among the surgical team, anesthesiology, nursing staff, the administration should be smooth, so that to have a very good, smooth workflow and patient care continuity. Next slide. So we come on the preoperative assessment. Preoperative assessment is crucial in the daycare surgery for several reasons, being it ensures patient safety, it can help to optimize the outcomes, it enhances the efficiency of the surgical care, and etc. So here now are the key important points highlighting the importance of the preoperative assessment. So to educate patients and carers regarding the day surgery pathways, I've said that earlier, to impart information regarding planned procedures, postoperative care, to help patients make informed decisions, also to identify medical risk factors, promote health, and optimize the patient conditions. These are the things that makes the preoperative assessment very important. So quickly jumping into the patient selection, preferably, or we can say in the past, daycare surgery were just done for ASA 1 or ASA 2 patients because they're stable patients. But current guidelines, they even propose ASA 3 and ASA 4 patients. So performing a daycare surgery on patient with ASA physical status classification class 3 and class 4 can be challenging due to the increased risk of perioperative complications that are associated with this ASA 3 and ASA 4. It can be challenged, but it is feasible under certain conditions with appropriate planning and resources. So here are some of the considerations for ASA 3 and ASA 4. In terms of surgical procedure, you have to make sure the procedure is short and minimally invasive so as to reduce the stress and the recovery time, and avoid those complex surgeries that has maximum blood loss or will impact the maximum food shift, electrolyte imbalance. We avoid those complex surgeries. And in preoperative optimization, optimize the medical condition before surgeries. Control the blood pressure if possible, manage the diabetes, improve the respiratory function. And if it's possible, it's better to involve other teams, the cardiologists, pulmonologists, for complete evaluation and optimization, if in case you have ASA 3 and ASA 4 patients. So they're not contraindicated for the day case surgery. So in terms of our anesthesia management for the ASA 3 and ASA 4, we prefer to use the anesthesia technique that minimize the physiological stress and allow for quick recovery. So if possible, the regional anesthesia where appropriate. So all in all, planning, preoperative assessment, and optimization is important, even though the patient is ASA 3 and ASA 4. So they can be included in the day case surgery. So on the medical history, so you should have a comprehensive preoperative evaluation to identify any potential anesthesia-related risk, including allergies, current medications, and previous reaction to anesthesia, of which these medical problems like that can increase the risk of perioperative complication and can also delay the recovery of the patient, which can necessitate admission of the patient. So other important thing is the fasting guideline. Ensure the patients are fasted prior to any elective surgery, but more important for the daycare case surgeries because it reduces the risk of aspiration and also avoid prolonged fasting. We know that prolonged fasting is associated with dehydration, hypoglycemia, electrolyte imbalance, impaired metabolic function, of which in general, this all can cause delayed recovery in the first place and increase the risk of perioperative complications as necessitating you to admit the patient. Next slide. So let's jump into the anesthesia techniques. So regardless of the technique you want or the technique you're required to choose, there are some of the consideration when it comes to the daycare surgeries. So we start with the general anesthesia. So in daycare surgery, the main aim of the general anesthesia is to ensure rapid offset of anesthesia with minimal complications, such as postoperative nausea and vomiting, dizziness and drowsiness, and rapid return of fully cognitive function. So with short-acting agents are preferred for both general and regional, for both general anesthesia, so propofol for induction and several and days for maintenance. This is because of their rapid onset and rapid recovery, of which is the main aim of the daycare surgery. So adequate analgesia also is important. We encourage the use of multimodal approach so as to minimize the use of the opioid, which can be sedative. And also we encourage on opioid sparing analgesia protocols. If you have your protocols that you can avoid opioids at all, well and good. So coming to the regional anesthesia. Regional anesthesia techniques such as spinal, epidural, and peripheral nerve block. So they play a significant role in daycare surgery because of its advantages with respect to analgesia and the reduction of opiate side effects such as postoperative nausea and vomiting, respiratory depression, urinary retention, and etc. So specifically, let's come to spinal anesthesia. So in case you have given your spinal anesthesia, so if possible, use low-dose short-acting local anesthetic agents, and this anesthesia should be targeted to a specific surgical sites. For example, unilateral spinals or saddle block for the perineal surgeries. This will help to minimize the complications such as hypotension and also minimize the motor blockage. We advise that the spinal anesthesia should be conducted with the 25 gauge or smaller pencil point needles, as this will help to reduce the incidence of post-dural puncture headache. So on the discharge instruction, if your patient have received spinal anesthesia, it should include information regarding the post-dural puncture headache and what to do if this can occur. Also, spinal anesthesia, we know that it is associated with motor blockage. So discharge criteria to enable safe mobilization post-spinal should include the return of sensation to the perianal areas in S4, S5, the plantar flexion of the foot at the preoperative level of strength, and also the return of proprioception in the big toe. So this criteria will enable you to classify your patient that maybe the patient is able to go home because of the self-mobilization post-spinal anesthesia. So you should have also the analgesic plan when the spinal wears off. And also the last thing on spinal anesthesia, you should rule out urinary retention before the discharge because they are associated with urinary retention. Okay, let's move to the peripheral nerve block and fascial plane nerve block. So both fascial plane and peripheral nerve block should be performed with the ultrasound guidance because ultrasound guidance improves the characteristic of the block, particularly the performance time and the success. And it also reduces the risk of complications such as vascular punctures and local anesthesia systemic toxicities. And it will enable you to use less volume, thus minimizing the risk of lasts. Next slide. So intraoperative management, the standard ASA monitoring, standard 1 and standard 2 as usual. We include the electrocardiogram, the blood pressure monitoring, the invasive or non-invasive, depending on the procedure, but preferably the non-invasive, the pulse oximetry, and the capnography. Those are the standard of which you should have intraoperative. In terms of airway management, we prefer the less invasive airway management. So the supraglottic airway devices, LMA versus endotracheal tube, would say like we prefer SGA, the laryngeal mask airway, but patients who are intubated, they can also be included in the daycare surgery. So fluid management is very, very important. We want to maintain our hemodynamic, yes, but we should also fear about the part of the fluid overload. So always check on the signs and symptoms of fluid overload so that to prevent pulmonary edema, which can cause respiratory failure, distress, and necessitating you admitting the patient. Multimodal analgesia, as I said earlier, combining different analgesic medications and techniques to minimize opioid use because they are associated with side effects such as nausea and vomiting, and they are sedative. Next slide. So the postoperative care. So we should have a very standard post-anesthesia care unit so that we can take care of our patient post-anesthesia. So the close monitoring in post-anesthesia is very, very important to ensure the stable vitals and adequate pain control. In terms of pain management, we have talked about that earlier. Effective postoperative pain management with oral or parenteral medication, often using non-opioid analgesics such as NSAID or acetaminophen, if indicated. Nausea and vomiting prevention, we want to give prophylactic for the PONV, postoperative nausea and vomiting, antiemetic, so as to reduce the incidence of postoperative nausea and vomiting, of which it can delay the discharge. So the next slide, it will show us the criteria for discharging these patients. Next slide. So what are the discharge criteria? So coming and by looking at this table, table number 2, this is the discharge checklist for day surgery from the British Association of Day Surgery. So vital signs should be stable and within normal ranges. So we should be able to maintain the stable vital signs. The patient coming in, you should have the baseline vital sign and be able to maintain the stable and normal range. Pain control, assessing pain using various assessment tools, depending on your settings. It can help you to assess and be able to manage the pain. So pain management, pain managed effectively with oral medication. That's the criteria. We want our pain to be managed effectively with oral medication. Nausea and vomiting minimal or well-controlled. Ambulation, able to walk without assistance. Oral intake, the patient should be able to tolerate fluids and if necessary, light food. Fully alert and oriented to people, place and time. And confirmation of a support system, a responsible adult to escort and stay with the patient within the first 24 to 48 hours. Next slide. So poll number 4. You've been consulted by your colleague regarding a 37-year-old female patient who have been classified as ASA 3 due to a medical condition, planned for the KY fixation on the 5th proximal phalanx fracture on of the right hand as shown in the X-ray below. Yeah, so 37-year-old female patient, she has a fracture requiring KY fixation on the 5th proximal. Yes, the patient is ASA 3. So what will you do? Will you postpone the procedure and advise for conservative management? Will you proceed with the daycare plan? Will you advise for a long admission plan? All the above and the above. So previously I talked about ASA 3 and ASA 4. So with thorough pre-operative assessment of optimization, it is possible to continue. And for the anesthesia technique, with those anesthesia which have which pose less physiological stress to the body, like regional anesthesia, can also be used. So you can do an ulnar block for this patient and be able to proceed with the daycare plan. Next slide. So criteria for selecting patient for daycare cases, these things are repeating themselves. Patient selection, I've talked about it. Medical history, I've talked about it. Let's talk on the psychosocial factors. You should have a reliable support system. So the bachelors at home who don't have support are not allowed. Kidding. So the patient should have a responsible adult available to accompany them home and stay with them for the first 24 hours post-operative. And the patient should be able and willing to follow pre and post-operative instructions. So this is very important, to keep on communicating with your patient, even if the patient is at home. Patient should have the emergency contacts. The patient should be able to be with someone who is responsible, adults, anayejielewa. Next slide. So this is the scoring. It has been written the scoring of the table, but this is the scoring of the patients who are at risk of admission. So these are the criteria. So basing on the points, they can tell you, they can stratify the risk if this patient is admitted or can be discharged. So next slide. So interpretation of the table, the score of 3 have 21 times the odds of admission compared to those with a 0 or 1 score. And score of more than 3 32 times odds. So it's like tell you like this patient is fit for admission, is fit for discharge. This patient is fit for admission. So there are many scores basing on your checklist and protocols. You should be able to have these scores or discharge criteria. So when you discharge your patient, you should be very sure that this patient won't get any postoperative complication. So long procedures, which can take more than 2 hours, should be done earlier the day. Transfusion is not a contraindication for the day case. The day case surgery is not restricted to ASA 1 or ASA 2. As I said before, ASA 3 and ASA 4 are appropriate candidates, providing they are stable. Next slide. Okay. Other criteria in surgical procedure point of view. So we look at the complexity and the duration of the procedure. We want the procedures which are lasting less than 2 hours, shorter duration procedures with low to moderate complexity, because these surgeries have a lower risk of significant blood loss, fluid shift, or postoperative complication. Postoperative pain management, we want our patient should be at a state of manageable pain with oral medication. So the procedure should be associated with manageable postoperative pain that can be controlled with oral analgesics or simple pain management strategies. So low risk of postoperative complications, these are minimum invasive procedures such as laparoscopic, endoscopic, or other minimally invasive techniques are preferred. These are some of the examples of the preferred surgeries: procedural surgery, incision and drainage, lap chole, lap appendicectomies, maxillofacial, manipulation and anesthesia of the fractured nose, and many other surgeries. Next slide. So facility capabilities. So for the part of the equipment and staffing, the facility must have a necessary equipment, medication, and staff trained to manage potential complication, a very stable and standard PACU for immediate postoperative monitoring and care, emergency preparedness, admission protocols, transfer arrangement in case of complications, also geographic proximity. The patient's home should be within a reasonable distance from the facility to facilitate return in the case of complication. So the patient should be at least near the facility, not very far away. Timing, the surgery should be scheduled early enough in the day to allow adequate recovery time in the facility before discharge. Next slide. So, principles of errors. Errors is the enhanced recovery after surgery. This is a comprehensive, we can say, approach to improving surgical outcomes by optimizing the patient care before, during, and after surgery. Traditionally, the recovery of surgery has been marked by the lengthy hospital stays, significant pain, and slow return to normal activity. However, these principles of errors is changing this narrative by introducing a set of protocols designed to enhance patient recovery, reduce complication, and shorten the hospital stay. So these fundamentals are based on 5 pillars, including the preoperative patient counseling, education and optimization, multimodal and opioid sparing analgesia, prophylaxis for postoperative nausea and vomiting, wound infection and DVT, maintenance of euvolemia, encouragement of early mobility. You can all agree with me that these principles of errors are heavily applicable in daycare surgery. Next slide. So to improve outcome in the daycare surgery, errors principle should be taken into consideration. Next slide. So winding up my presentation, these are the two articles concerning daycare in lower middle income countries. I have one article from Muhimbili National Hospital, the other one from SMC. So starting with the article from MNH, it was a case series whereby the randomly selected patient who underwent laparoscopic Heller's myotomy and fundoplication for the achalasia cardia at Muhimbili National Hospital in Dar es Salaam, Tanzania. So in this case series, they observed that an event postoperative in hospital course marked by significant improvement within 24 hours following the surgeries. However, all the cases that were done at Muhimbili had a relative extended hospital stay. And these are attributed to many factors, from healthcare provider, patients themselves, and facility-related factors. So in this article, some of the challenges that were highlighted, unfavorable attitude towards same-day discharge among healthcare. So among healthcare workers, people had different attitude towards the same-day discharge, and also the suboptimal preoperative anesthesia review and poorly executed discharge plans. Additional factors where the patient themselves were skeptical of the daycare surgery due to insufficient preoperative counseling, so they did not receive a very good counseling and education and the information on what to expect. Poor access to healthcare facilities, the absence of dedicated day surgery units. So at least you should have a unit that is specifically for the daycare surgeries. Other challenges included the resource limitation, insufficient staffing, access to suitable medications. These are the challenges that led to failure of this patient who underwent laparoscopic daycare surgery. They were discharged after 24 hours, of which is not inclusive in the criteria for the daycare surgery. Other article from Kilimanjaro Christian Medical Center, a daycare laparoscopic cholecystectomy at KSMC. So at KSMC, the laparoscopic cholecystectomy as a day case started early in 2017. And this service was the first of its kind in the sub-Saharan Africa. So this article aimed to evaluate the service in terms of safety, feasibility, and acceptability by the patient and staff. The results were 147 laparoscopic cholecystectomy were completed, whereby 109 were planned for daycare laparoscopic cholecystectomy, whereby 82 patients out of 109, that is 75.2%, were successfully, and 27 patients, that 24.8%, these patients were admitted. So they failed, you can say. So the main cause of this is the complication, being pain, nausea and vomiting, hypotension. So in conclusion, from these two articles, there are high rates of daycare laparoscopic cholecystectomy with low rates of complication. Administrative problems preventing KSMC from reaching its fully daycare laparoscopic cholecystectomy potential. HOD is listening. Actually, right now there's no administrative problem in this. A dedicated daycare surgery unit would address most of this problem, and collaborative efforts are necessary. Now, from this article, we were able to get some of the recommendations, which are available in the next slide. So on the part of the recommendation, so I can't really read everything here to be boring, but I will try and summarize I can easily categorize the recommendation based on different points and different factors, starting on the patient selection, establish a clear criteria so as to determine the suitability of the patient for the daycare surgery, of which this will include a clear history, physical status, the ASA classification, and be able to determine the complexity of the procedure, risk stratification, so as to can ensure the safe surgery and the patient to be able to discharge on the same day. The conduct of thorough preoperative assessment, we have said this earlier, and also patient education. It is recommended to provide a detailed information about the procedure, anesthesia, fasting guideline, postoperative care, obtain the informed consent. The patient has to know what to expect, has to be aware of everything that is going to happen so that it can actually help to reduce the failure of this. So other recommendation on the facility standards. So accreditation and licensing, you should be able to ensure that the facility is accredited and meets all regulatory standards. Maintain well-equipped operating rooms, preoperative and postoperative areas, emergency facilities, and don't forget to implement strict infection control protocols. Ensure a sufficient number of qualified staff, such as surgeon, anesthesiologists, nursing staff, support personnel. Perform regular training and assess the competence of all of your staff involved in the daycare surgery. And when it comes to the anesthesia and pain management recommendation, use standardized anesthesia protocol tailored for outpatient surgeries. Implement effective pain management strategies, including multimodal analgesia to minimize opioid use. Continuous monitor vital signs, oxygen saturation, and other relevant parameters during and after surgeries. So standard operating procedures, the SOP, we should follow evidence-based surgical protocols to ensure safety and efficiency. Utilize minimum invasive technique to reduce recovery time and complication. And you should have emergency equipments and protocols in place to manage complication. Winding up, follow-up care, I've said about the telephone follow-up. You conduct a follow-up call within 24 to 48 hours to assess recovery, address concerns, reinforce discharge instruction. Also, you can have an in-person follow-up, schedule follow-up visits if necessary to monitor recovery and manage any complication. Also, don't forget quality and safety. Quality assurance, you should have regular audits and implement quality assurance programs to monitor outcomes and improved care. You should have patient safety protocols, including the WHO surgical checklist, infection prevention measures, and etc. By saying so, I would like to say thank you. That's the end of my presentation.
Thank you very much, Kev. That was wonderful, and I really enjoyed listening. It was quite informative. As you said, I hope KSMC, they have taken care of the administrative issues. So I welcome the floor, and if there's anyone with experience from any teaching hospital or national hospital, I know we have our senior colleagues. So welcome. If you have a question, please unmute yourself, then you can ask, or you can type it in the chat box. There's one question regarding Beer's blog, so maybe I'll start with that one. What is your experience with Beer blog as we are talking about the daycare surgeries? Maybe Ngaba or Picho, if you have experience on that, can you please respond?
So anyone with experience, actually I don't have experience with the BS block.
Yeah, hello, Sweetbet. Yeah, I think I equally have a similar comment. I have no personal experience with the Beers block on patients that require day case surgery. And unless I wanted to proceed with another comment, but anyway, let me check. Let me see if somebody else can take this up. Then I'll come through with a follow-up contribution.
Okay, thank you. But I don't think, of course, I don't have experience with the beer block, but regarding the upper limb surgeries, I'm trying to think because nowadays you can with the ultrasound, you can target whenever you want. As for example, in the presentation, Kevin mentioned you can do the ANA just for the case to be presented, but also you can go, maybe you can do auxiliary if necessary, depending on the indication. I don't think if people they are really doing BS block nowadays, but if it's someone with experience, please, sure. But I don't have experience with the BS block, but I have experience with the other blocks regarding daycare surgery, which actually they work better. Okay. Another question. Okay, they have been answered in the chat. And so please, if you have a question, please unmute yourself, and then you can ask. Maybe I can welcome the senior colleague with us, Professor Dati. Please, can you please unmute yourself and share experience? We would like to hear some word from you. Dati, please, welcome.
Hello, Dr. Sweetbet.
Hello, Karibu.
Yes, I think whilst Dr. Dati is coming in, I just wanted to make a quick contribution on something that I think the presenter, mentioned, just so to emphasize. So I think day case surgical services, I think for most facilities, it's sort of becoming a new concept. And also, I would know that the cases that are usually done under local anesthesia, would be the sort of easiest cases to consider as day case surgery. I think this is so for most facilities that are practicing the low-level day case operations. So for the other cases that sort of become more complex, requiring invasive airway or much more aggressive anesthesia, I think the story becomes even more complicated, because then I think patient safety becomes key. And in this particular case, like the presenter, Dr. Kevin, had mentioned, systems are very important. If we're going to give more complex anesthesia for day case surgeries, I think that needs to override on a stable system of inpatient operative care. A stable system, because you agree with me that day case operations in certain settings may have a tendency of being abused, especially by our colleagues, the surgeons. If they see that, you are able to do a case on a day, on a daily basis, it's very easy for them to think that every other case can actually be done, because, they are so ambitious to operate on a patient given every opportunity. So it's something that requires strict systems in place for both preoperative, intraoperative, and postoperative care. coupled with, I think, multidisciplinary coordination involving anesthetists, surgeons, theater, recovery and ward staff, because everyone is involved in that process. So a stable system is required to avoid day case surgical services from being abused and therefore compromising on patient safety. Then secondly, just again to emphasize that patient selection is very, very important, bearing in mind that we need to understand our the equipment situation or the resources that we have on the ground and the ability to be able to provide safe day surgical cases. So patient selection, I think for me, is key, and we need to understand our capabilities and limitations as facilities for us to undertake this form of specialized surgical services. Thank you. I thought I should highlight some of those points. Thank you, the moderator.
Thank you, Ndaba. And then so we'll give chance to Professor Dati, and then I saw another colleague, Dr. Limba. You would like to hear your experience on that. Then after that, we will share the poll we did to see how the answer went. But Professor Dati, please welcome.
Thank you very much. And my apology that I completely forgot. I just joined when you were concluding and the recommendations were being read. Nonetheless, I want to emphasize that I'm happy in the recommendation. I saw two of such recommendations that I like. I had the opportunity to present recent advances in daycare anesthesia. And the emphasis now is like in the recommendation, say that it's not only the ASA status now, there is a shift now. You look at the general condition of the patient. In fact, the current thinking, I think in the UK, they are shifting towards, like if you say you stay with the ASA status, you only get a few stable ASA 3. But now is that those with comorbidities and they are to undergo some minor to moderate procedures, surgical procedures, you consider them as day case first. When they are optimum, their condition is optimal, it's better to do them as day case rather than the other way around. So what they are trying to say is that it is every case, every surgical procedure now should be considered as day care until proven otherwise. So that's the template. But successful day stay anesthesia and surgery is premised on strong protocols and policies, like you said, multidisciplinary approach. And then the facility must be ready to invest in very good equipment and also drugs that you can actually do what you call fast-tracking anesthesia. That is the key. So when that is in place, it's a win-win situation. Thank you very much.
Thank you very much, Prof. Dr. Ruimba, please unmute yourself and then share your experience with us. As we're waiting for Dr. Ruimba, please, Mariam, can you share the answers for the poll we did?
So this is poll 1. So which of the following, oh, okay. Which of the following should be one of the minimum standards for provision of safe day case surgery? So it was all the above, because appropriate patient selection and screening, the minimum standard, ability to provide emergency care, appropriate health care workers cover until patients are discharged, and ability to provide fully post-operative inpatient care in case of any complications. So all the above was the answer. For number 2, which of the following is true about the day case surgeries? So you have to choose a most correct answer. The answer was the patients for day case surgery should be selected carefully. We have seen that with carefully assessment using criteria, thorough preoperative assessment, optimizing the patient medical conditions. This will help you to get a very stable patient so that the patient can fit into the daycare case surgeries. So should be selected very carefully. Next. For number 3, what are the advantages of daycare cases over the long admission surgeries? The answer was all the above, because quick recovery with better outcomes, avoid complications of long admission surgeries like DVT and pneumonia due to prolonged hospital stay. You've seen that they have cost implication up to 75% of the hospital cost can be saved, or increased number of surgery performed because it increases the flow, patient turnover between one procedure to another one. So all the above was the correct answer. For number 4, I answered this question while presenting. Answer 3, patients for K-wire fixation on the fixed proximal pharynx. Will you proceed with the daycare plan, even though the patient is a 3? So as the professor said, we don't really need the answers nowadays. We just have to assess the stability of the patients. So with very good patient selection can help you be able to have this patient stable for surgery. So you will proceed with the daycare plan with minimum invasive, with the anesthesia technique that is as low risk on the physiological status of the patient. The regional anesthesia, a peripheral nerve block can be done here. Next.
That was the last poll.
Okay, thank you.
Thank you very much, Kevin and Mariam. So I will welcome Magdalena to do the last part. And I think before Max, I would like to thank everyone who been in this webinar. I hope I'll see you in the next one. And always welcome. Max, please continue.
Thank you to all our participants. I would like to a special thank you for the panelists, especially Dr. Kevin Mero. Thank you so much for taking the team through the daycare surgeries. Mine is to just let you know that as Gradient, we continue to focus on access to anesthesia, safe anesthesia, safe surgery, and also critical care. So we have particular equipment, the universal anesthesia machine, the Prima. We also have on the ventilation, we have the the ICV, and one upcoming machine, the KO2 for oxygen supply. So we thank you so much. And in case you want to reach us, and Miriam had shared some of the websites. Yeah, the customer@gradienthealth.org. Please feel free. And soon and very soon, we are going to start our webinars on the use of our machines also. So for those of us who have access to any of our machines, please let your colleagues know that soon, in case of any questions, any queries about the use of our machines on your day-to-day work, please send in those questions to customers@gradienthealth.org so that our panelists can be able to assist you with any challenges. Thank you so much. Yeah.
Thank you. As I said, I think now it's the end of our session. Please, if you have a question, you can send it to the customer at Gadia, and we will come back to you. Until next time, stay blessed.
Thank you. Bye-bye.
Thank you, everyone.